And it gives me a great pleasure to introduce our speaker today, Dr. Christy Russell. Dr. Russell received her medical degree from the Medical College of Pennsylvania in Philadelphia. She completed a residency in internal medicine at the Good Samaritan Medical Center at Phoenix Veterans Hospital in Phoenix, Arizona, and also completed a fellowship in hematology oncology at the Los Angeles County University of Southern California Medical Center in Los Angeles. Dr. Russell joined the USC Department of Medicine faculty in 1986. She served as the Medical Oncology Fellowship Training Program Director from 1991 to 2008. She was also the Chief of Staff at the USC Norris Cancer Center from 1994 to 1996. She remained on faculty for 31 years and served in many capacities, including the Director of the USC Norris Breast Cancer Center, the Director of the Utilization Review at the Norris Cancer Center, and the Co-Chair of the USC Comprehensive Cancer Center Data Safety Monitoring Board. Dr. Russell joined Genomic Health as the Senior Director of US Medical Affairs in January of 2017. And she then transitioned to Vice President, US Medical Affairs in August of 2021. On top of this, Dr. Russell served on the American Cancer Society Cancer Action Network National Board of Directors. She was also chairman of the board and served as a leader as well, the California division of the American Cancer Society, and was president of that board from 2002 to 2003. Clearly, Dr. Russell's very accomplished, and we are very fortunate to have her as our speaker today. And with that, I'll pass it on to you.
Thanks so much, Kasia. Appreciate everybody dialing in. I would have preferred to be in Toronto, but I am in Los Angeles, and it will be 80 degrees here today, so I'm actually not complaining. Give my disclosures, I am an employee of Exact Sciences, which was previously known as Genomic Health, and as you know, we have the Oncotype breast product. So I want to walk through, I know this is somewhat of a varied audience, the history around discovery and validation of the Oncotype score. It was originally created back around 2000 with a 21 gene score, and it was found in studies to be a prognostic assay for women who were lymph node negative with hormone receptor positive early breast cancer. And there's a large trial called B20, which we had the samples from to validate the score for prediction of chemotherapy benefit in the node negative population. Now, the overall study and the outcomes from the patients from the B20 are on the two black lines here, with patients receiving chemotherapy having an overall 4.5% relative or absolute benefit from chemotherapy. And when we tested the recurrence score for those patients with the low score, there was no chemo benefit. Patients with an intermediate score, there was no obvious chemo benefit, and it all seemed to be in the group of patients who had the high score, which at that time was defined as 31 to 100. And if you take patients that have, and you do scoring and you use the whole range of scores of 0 to 100, it is predictive of chemotherapy benefit with an interaction p-value of 0.038. That then led to the TAILOR-X trial, which I'm presuming you're aware of, but this was the large phase 3 randomized trial of women who, again, with hormone receptor positive, HER2 negative, lymph node negative breast cancer. 10,000 women were placed on this trial. And the question was, if you have a mid-range recurrence score somewhere between 11 and 25, does anyone in that group get chemotherapy benefit? And the statistics from the B20 trial suggested that perhaps 20 to 25% of patients, we could begin to see these curves uncrossing and that there would be chemotherapy benefit. So with the 10,000 patients in the trial, trying to see that chemotherapy benefit and where it occurred and where the curves uncrossed between a recurrence score of 11 to 25, the results showed with 9-year invasive disease-free survival, and 9-year distant recurrence-free interval, that there was no chemotherapy benefit if you had a recurrence score 11 to 25. So people have said in patients with lymph node negative breast cancer who are hormone receptor positive, HER2 negative, what percentage of those patients actually have a recurrence score between 0 and 25? Is this the minority of the patients, the majority of the patients? And in fact, in our database, patients with recurrence score between 0 and 25 represent somewhere around 80% of patients with node negative, hormone receptor positive, HER2 negative breast cancer. So it addressed a large group of women who previously had been receiving chemotherapy for which we could find no benefit from chemotherapy. And from TAILORx, with multiple subgroup analyses that were performed, there was one group with a recurrence score 11 to 25 who did seem to get chemotherapy benefit. And it wasn't typical things that you think of. It wasn't tumor size. It wasn't grade of the cancer. It had to do with age. And the trial showed that for women who are over the age of 50, that there is 0 chemotherapy benefit, even in all subgroups, large tumor size, high grade. They just could not find chemotherapy benefit in women in the trial who were over the age of 50. But for women who are 50 and younger, we see a really different pattern of chemotherapy benefit. So on the left are the 9-year distant recurrence rates, distant recurrence free rates. And you can see that as the recurrence score goes up, you're having more events that occur, and that the curves tend to uncross somewhere in the mid-teens of recurrence score. So again, 50 and younger, we're starting to see a different pattern than women over 50. Now we took that curve from the left and created these bar graphs to say, okay, patients with recurrence score 0 to 10, they never got chemotherapy. They weren't randomized. They only got endocrine therapy. And women with a recurrence score 26 to 100, they all got chemotherapy with their endocrine therapy. So the question is recurrence score 11 to 25 in the premenopausal women, or the women who were 50 and younger, from TAILORx. If you had a recurrence score 11 to 15, we did not see any chemotherapy benefit. If the recurrence score was 16 to 20, there was an absolute 1.6% chemotherapy benefit. And if the recurrence score was 21 to 25, there's an absolute 6.5% chemotherapy benefit at 9 years to prevent a distant recurrence event. And when these data first came out several years ago, because this was published in 2018, I think people had pretty strong opinions about whether the 16 to 20 was meaningful for them or not. Clearly, the 6.5% absolute chemo benefit seems to have really significant, in my mind, chemotherapy benefit. I think people struggled a little bit more with the 16 to 20. So then what happened is a second presentation occurred from Dr. Sperano and then published in the New England Journal of Medicine in 2019. And that was to add clinical risk on top of the recurrence score. And clinical risk is defined from the trial. It's adding grade to tumor size so that you're getting 2 clinical features that independently are prognostic but do not predict chemo benefit. And the question is, if you have a certain recurrence score, do those clinical features influence the amount of chemotherapy benefit women are getting? And so with this and the predefined low clinical risk, in that group of women with recurrence score 16 to 20 that are getting an absolute 1.6% chemo benefit, if you were low clinical risk, you didn't even see the 1.6%. There was no chemo benefit. But if you were high clinical risk, you actually did see substantial chemotherapy benefit. And if your recurrence score was 21 to 25, all those patients seem to get, I think, clinically meaningful chemotherapy benefit as part of this large randomized trials. So clinical features matter for prognosis. They just can't predict who will and will not benefit from chemotherapy. So with those data in mind, looking at this premenopausal women who are sitting with higher risk clinically and a lower recurrence score where they start to get chemotherapy benefit, The study went on to look at other features, but we now want to address the issue, how about women who are lymph node positive? Because lymph node positivity is the ultimate poor prognostic group for women who are hormone receptor positive, HER2 negative breast cancers. And so the question is, what do we know about this Oncotype 21 gene recurrence score in lymph node positive patients? The first data I want to show you are from our commercial database. And it is looking at the distribution of recurrence scores in over 600,000 cases for whom we had performed an Oncotype score. And we looked at the distribution of recurrence scores for those women who were lymph node negative, N1 MYC, or had N1 and higher. And so I would have presumed before I saw these data that for women who have lymph node positivity, that the chances are, even though we know they're hormone receptor positive, HER2 negative, you would see a higher distribution of recurrence scores in that high range. And that is not what was seen. So if you look at the right-hand side bar graph on each of these three different groups, and you say the gray is recurrence score 0 to 25, and the orange is recurrence score 26 to 100, where we know we're starting to see substantial chemotherapy benefit. It doesn't change whether you're lymph node negative, N1 MYC, or N1. Now, to validate the Oncotype score in lymph node positive patients, the one randomized trial that we had access to where women were randomized to endocrine therapy with or without chemotherapy is an old trial from the Southwest Oncology group called SWOG 8814. Relatively small number of samples that were tested, and these women are all post-menopausal. But the women in this trial were randomized to tamoxifen for 5 years or CAF chemotherapy plus tamoxifen. And that trial showed something very similar to the B20 lymph node negative trial, which is it isn't until you get into these higher recurrence score ranges where you begin to see chemotherapy benefit. But again, these are all postmenopausal women. And in addition, it was again predictive of chemotherapy benefit by the interaction of chemotherapy, recurrence score, and outcome of the patient. Well, they took those data from the 8814 trial and looked at the curves of the women who had a recurrence, who had 1 to 3 positive lymph nodes, so N1 patients. And these are the curves from 8814, and we've just drawn a green arrow where the patients from RxPONDER, that level and below sit. So when the trial was being created, they elected to not randomize anybody above 25 because you can see increasing chemotherapy benefit to prevent a disease-free survival event over a recurrence score of 25 in postmenopausal women who are lymph node positive. And so the question was not just postmenopausal women, but pre and postmenopausal women. Let's randomize the patients with a recurrence score 0 to 25. That trial was performed and was finally published in the New England Journal of Medicine this past December 2021. So let me take you through the trial. This is a trial that is asking the question, if you have 1 to 3 positive lymph nodes, you're over the age of 18 or over, and you have a recurrence score of 0 to 25, do you get chemotherapy benefit? And so the plan was to randomize 5,000 women to their standard endocrine therapy alone versus standard chemotherapy plus endocrine therapy. There are 3 stratification factors. They took that recurrence score of 0 to 25 and broke it in half. So they've stratified the patients 0 to 13 or 14 to 25. They have assessed menopause status, which I'll review with you with their definition of menopause status. And then they looked at what nodal surgery the women had, whether it was sentinel lymph node biopsy or axillary lymph node dissection as the final axillary surgery. So the primary objective was, is there chemotherapy benefit if you have a recurrence score 0 to 25 and you're lymph node positive? And if you do have chemotherapy benefit, is it dependent upon the recurrence score? In order to get 5,000 randomized patients, they had to register almost 9,400 women. So women were registered, they signed 2 consents. They signed a consent to be registered, to be tested. And then once they got their score back, they signed another consent that agreed to be randomized. And so although we had 9,400 women who registered, the majority of women declined to participate after they were given their recurrence score. Only 1,000 of those patients had a recurrence score over 25, and they were thus not eligible. Patients who were found to have a recurrence score 26 to 100 are not part of this trial, and they are not being followed. As the trial was progressing, the statistical plan was to do 5 years of follow-up from the last patient who had been placed in the trial. And the last patient who was placed in the trial was in 2017, actually September 2017. And we presumed that the first analysis would not occur until at least September 2022, and that we might see data in 2023. However, there were interim analyses being performed with this trial, and thus there were 3 analyses that were done. The first 2 just recommended that the study continue, but with the 3rd analysis that was performed in September 2020, with only 49% of the expected invasive disease-free survival events, the investigators, it was recommended from the Data Safety Monitoring Committee to the investigators and to SWOG that they should report the data. And it was basically around the outcomes of the premenopausal women. So reporting early, but the suggestion from the statistician is the overall outcomes would not change over time. So that first presentation occurred in December 2020. Now, the decision was made in September to release the data. They got an immediate agreement from San Antonio Breast Cancer Symposium that they could present the data there. And when they presented the data, it was at 54% of the events. The median follow-up was 5.1 years, and the endpoints reported were invasive disease-free survival and overall survival. All right, so when they then wrote the paper for the New England Journal of Medicine, they submitted that like in April or May of 2021, but it didn't get published till December 2021. And so you have just a couple more months of follow-up. And then a final presentation occurred just 2 months ago at the San Antonio Breast Cancer Symposium with even more updated results, with now a median of 6.1 years of follow-up. The endpoints that they're reporting with these 3 different reports are changing. So originally we saw invasive disease-free survival. The manuscript now includes distant relapse-free survival, and then the oral presentation at San Antonio includes those 2 plus distant recurrence-free interval. So what I'd like to do is explain to you those 3 definitions, because they're part of all the data that are being presented. IDFS is 5 things: death, either from breast cancer or death from any cause. And then other definitions within IDFS are any local or regional invasive recurrence, so chest wall, in the breast, in nodes, distant recurrence, or a second invasive primary cancer, whether it's breast cancer or not. So IDFS has a lot of stuff in it, as we commonly see in large phase 3 randomized trials. Distant relapse-free survivals are both causes of death, either from breast cancer or from any cause, and distant recurrence. And I think the tightest definition here is distant recurrence-free interval, which is death from breast cancer or distant recurrence. And I would suggest to you that you should not be dying from breast cancer if you haven't already had a distant recurrence. The updated data, when they looked at invasive disease-free survival now, with the two randomized arms, okay, everybody's got a recurrence score 0 to 25, and they're randomized to endocrine therapy with or without chemotherapy, showed an absolute 1.2% chemotherapy benefit over endocrine therapy alone. It is not statistically significant. You can decide for yourself whether you think that 1.2% absolute chemo benefit is clinically meaningful, but we will present the varied data by menopause status, where the numbers are quite different from one another. One of the things I want to talk about is their definition, Southwest Oncology Group's definition in this trial of menopause status, because the data between pre and most postmenopausal women in this trial look so different. It's important to understand what is the definition of premenopausal versus postmenopausal. To be called postmenopausal in this trial, you could have had your ovaries removed. That's a standard definition. Or it is 12 months since your last menstrual cycle. To be premenopausal, you have to be within 6 months of your last menstrual cycle. You have to have your uterus and ovaries in place, and you can't be on any kind of hormone therapy that would cause you to cycle and have a period. If you don't meet either of those criteria, let's say your last period was 9 months ago, then they use the categories of age to assign you to pre or postmenopausal. So if you're more than 12 months, you're postmenopausal. If you're within 6 months of a period, you're premenopausal. If you're somewhere not meeting those criteria, then if you're under 50 or 50 and older, being pre or postmenopausal. Now, when you look above in terms of what is the age grouping of the women who are premenopausal, 30% of them are age 50 to 59. And so you're getting women who are in an older age range that are premenopausal. So TAILOR-X, for whatever reason, age, which is a much stronger statistical determinant of outcome for the younger women and chemo benefit, here menopause status is what the stratification factor was. Now, knowing those definitions, the postmenopausal women from RxPONDER, which is about 2/3 of the women in the trial, had no benefit from chemotherapy with any of the 3 endpoints, but I'm showing you the curves here for invasive disease-free survival, those 5 outcomes, or distant recurrence-free interval, which is either death from breast cancer or distant recurrence from breast cancer. There is no evidence of chemotherapy benefit for any of these outcomes. And when we look at the forest plot, so you have a hazard ratio of 1, which is the straight line that is vertical. You can't find any group who is getting chemotherapy benefit. Even those women who are grade 3 are not seeing chemotherapy benefit. Even the women who are 2 to 3 positive lymph nodes, there's no chemotherapy benefit. So the things that we would have thought of that would have driven us to use chemotherapy, if you are postmenopausal, you will not get benefit from chemotherapy. And so just using clinical features to make that decision in a node positive patient probably will result in substantial overtreatment. For premenopausal patients, it's a really different story. And so for invasive disease-free survival, there's an absolute about 5% benefit from chemotherapy. For distant recurrence-free interval, again, death from breast cancer or metastatic breast cancer, there's a 5-year distant relapse-free interval of about 2.4% absolute chemotherapy benefit. It's a little lower if the recurrence score is 0 to 13 as a group, it's 2.3% absolute benefit. And for women with a recurrence score 14 to 25, the absolute benefit is 2.8% at 5 years. And when we look at the forest plot of the premenopausal women, it's a really different story from the postmenopausal women. And it looks like the only group here who is benefiting, who is not benefiting from the chemotherapy are the women who are premenopausal, but 50 and older. And although it's wide confidence intervals, it is a different picture from what you're seeing of the other clinical risk groups. They've also looked for both pre and postmenopausal on lymphovascular invasion, extranodal extension. Nothing falls out as being different. If you're premenopausal, there appears to be chemo benefit, and if you're postmenopausal, you do not. The one exception of the premenopausal women who are 50 and older, and I'll leave it to physicians treating breast cancer patients as to how they interpret these data. Now, one of the presentations also, and what was asked to be done by the New England Journal of Medicine, was to look at this question of how about increasing recurrence score in the premenopausal women? Can we look at invasive disease-free survival? These curves have not yet been generated for distant recurrence, which it will be undertaken by us when we get the individual patient information. And so, although these curves don't look like they're spreading out, in fact, they are. And so patients who are sitting at the lower range of recurrence score have a much better prognosis than those who are sitting in a recurrence score range of 20 to 25. It's a very, very prognostic score. There is apparently chemotherapy benefit for all women who are premenopausal, but the amount of absolute chemotherapy benefit changes as the underlying risk changes. And I, in a very simplistic way, view this as everybody seems to be getting a relative 50% chemotherapy benefit to prevent an IDFS event. So if you're sitting at the lower range of the score, so let's say you have a 5% risk if you take endocrine therapy alone, then a 50% reduction will give you a 2.5% absolute chemo benefit. However, if you're sitting at the higher range, your risk of an event within 5 years is about between 15 and 20%. So that if you reduce that by half, your absolute chemotherapy benefit may be somewhere between 7.5% and 10% absolute chemo benefit. So because it's prognostic and because the underlying risk is changing, even if the hazard ratio doesn't change and it's a relative 50%, the absolute chemotherapy benefit is changing along with the prognosis. Now, at the San Antonio meeting this year, Dr. Kalinsky, who's the PI on the trial, presented 3 new analyses addressing the findings in premenopausal women. One is the question of micromets. And so again, the definition of micromets is the correct definition, which is 1 lymph node involved, and the micromet has to be less than 0.2 millimeters in size in 1 lymph node. If you have micromets in more than 1 lymph node, you're considered to be N1. Now, in the trial, when they were conducting the trial started in 2011, went to 2017. In 2014, the investigators thought that perhaps the number of patients who were being enrolled with N1 MYC was perhaps getting higher than they wanted it to. It's really a question of lymph node positivity, not a question of N1 MYC patients. And so after about half of the total population had been accrued, about 2,500 patients, they closed the arm for which N1 MYC were eligible. So everybody after that had to have 1 to 3 positive lymph nodes with macrometastases. And so because we had this finding in premenopausal women where chemo benefit, the question is, how about the N1 MYC premenopausal patients? So I'll show you those analyses. The second question is, we don't know why postmenopausal women are getting no chemotherapy benefit if their recurrence score is 0 to 25, but premenopausal women are. And the only difference here is not the clinical features. The only difference with this group of women is that they're continuing to have ovarian function. And the question is the chemotherapy benefit here actually an anti-cytotoxic effect on the cancer cells from the chemotherapy? Or is it the cytotoxic effect of the chemotherapy on the ovaries? The ovaries are shutting down, thus you have a much stronger endocrine therapy for the patient. And is that why they appear to be getting chemotherapy benefit? It's all about ovarian function suppression. So they wanted to do an analysis on women who were not randomized to ovarian function suppression, but had been given the ovarian function suppression as part of their therapy. And I'll show you those data. And the third data that they looked at and analyzed were women who were premenopausal and having periods. They were all keeping diaries about whether their periods stopped or not. And that was recorded into the data from the trial. And what they wanted to do was an analysis for those women who stopped having their periods versus those women who continued to have their periods, whether they got chemotherapy or not. So these three analyses, first one is micrometastases. There are only 206 premenopausal women who had micromets. The total number of women who are premenopausal in this trial is about 1,700. So only 206 of them have micrometastases. Of these 206, 22 of them have had an IDFS event. They have not broken out what those events are, but there is statistically absolute chemotherapy benefit for these women. So there was caution associated with this because of the small number of patients, the small number of events, but having N1-MYC and being premenopausal doesn't necessarily clear you from the benefit from chemotherapy. The second analysis, as we spoke, are those women who were given ovarian function suppression as part of their initial therapy. And that included women who got chemotherapy, and that included women who got endocrine therapy alone. So on the left-hand side, those curves are at the 6-month period of time is when the curve starts. And that would be 6 months since randomization. The orange curve on the bottom are those women who were premenopausal and were randomized to chemotherapy. And you can see that about 3% of them were initiated on ovarian function suppression within the first 6 months of being randomized to chemotherapy. And interestingly enough, between 4 and 5 years into the trial, about the same number of women are still getting ovarian function suppression. So adherence seemed to be pretty good. The gray line on the left are those women who are randomized to endocrine therapy alone. Now, presumably because they were premenopausal, they were being given tamoxifen. And you can see that about 16% at that 6 months after randomization were getting ovarian function suppression, and that continued out pretty consistently over the 5 years of therapy on the trial. Now, on the right-hand side of the landmarked 2-year IDFS outcomes for those women who got ovarian function suppression versus did not if they were assigned to endocrine therapy alone. So just the gray bar from the left are informing the patients on the right. They start the landmarking at 2 years to see if the ovarian function suppression may be having an effect on outcome, and they wanted to give enough time to be on ovarian function suppression to see that. Anybody who relapsed within that first 2 years are not on these curves. So looking at the patients who were randomly assigned to endocrine therapy, you can see that's about 730 women. At 2 years, there doesn't seem to be a difference between those women who had ovarian function suppression added to their endocrine therapy versus those that did not. Now, these data are pretty biased. They're biased because we don't know why women were offered ovarian function suppression. It is possible that the women who were offered ovarian function suppression had much higher clinical risk features and thus would have had more events. And thus, by giving them ovarian function suppression, they come up to the level of those women who got tamoxifen alone. Or it could be that ovarian function suppression is having no effect here. We don't know. They did the analysis, but there's no real conclusion from this analysis. And then the third analysis is looking at women who continued to have regular menstrual periods over the time that they were enrolled in the RxPONDER trial. Again, the gray line on the left are those women who were randomly assigned to endocrine therapy, and the orange curve are those who received chemotherapy plus endocrine therapy. Again, the curve started 6 months after randomization, and you can see that this is the reporting of periods, that over time, regardless of what your randomization was, that you were less and less likely to continue to have periods, even for those women who were randomly assigned to endocrine therapy alone. Over that 5-year period of time, we went from about 50% of patients at about 6 months after the randomization of having regular periods down to 18%. Some of that is because the women are aging, probably going through a normal menopause, but some of that may be the effect of the therapy and causing the periods to stop. So knowing that, they did an analysis of the women in both randomized arms. What is your outcome if your period stopped versus did not stop? And these data show that regardless of your randomization, the darker lines on top are the invasive disease-free survival outcomes for those women whose periods stopped versus the lighter colored curves below for those women who were continuing to have regular menstrual cycles. And that's a relative 50% improvement in outcome if your periods stop. Does that mean that all this chemotherapy benefit, which is a relative 50% chemotherapy benefit, is because of ovarian function suppression? We have no idea. This trial cannot answer the question, but it is certainly conjecture that that may be one of the reasons why we would see chemotherapy benefit in the premenopausal women and not the postmenopausal women. As a result of the first presentation from from the RxPONDER data, and on top of the TAILORx data, NCCN guidelines changed almost a year ago, and I just want to review those with you. So their guidelines are for postmenopausal women who are node negative and have a cancer over 5 millimeters, or patients who are postmenopausal N1 MYC or N1. The wording from the NCCN is strongly consider a 21 gene assay, which is the Oncotype score, and that if her result is 0 to 25, you should offer her endocrine therapy alone. And if her result is 26 to 100, you should offer her adjuvant chemotherapy plus endocrine therapy. Because patients with 4 or more positive lymph nodes were not involved in either of these trials, any of these trials, right now, nothing more can be said other than offer them adjuvant chemotherapy followed by endocrine therapy, even though it's likely patients with 4 more positive lymph nodes with a low score are not getting chemo benefit. We can't say that from any large randomized trial. And we do know their underlying prognosis and risk is poor. For premenopausal women, this is divided into 2 groups. For the premenopausal node negative women, the current recommendation is if the cancer is over 5 millimeters, that you should strongly consider the 21 gene assay, the Oncotype score, and then use that score to make your recommendation around her adjuvant therapy. The recommendation is that if her recurrence score is 0 to 15, offer her endocrine therapy alone, although you could consider ovarian function suppression. If it is 16 to 25, you could give her chemotherapy. There are some of those women do get absolute chemo benefit, or adjuvant endocrine therapy plus ovarian function suppression. And if she's premenopausal node negative and her recurrence score is 26 to 100, you should offer her chemotherapy followed by endocrine therapy. Now, it's interesting, this recommendations around that recurrence score result 16 to 25 is not based on level 1 evidence. Patients were not randomized in TAILORx to ovarian function suppression, but there's some very strong belief that that is the cause of the improvement in outcome of these women related to their chemotherapy, not a chemotherapy effect, but an ovarian function suppression effect. And finally, NCCN is suggesting that women who are premenopausal, either N1 MYC or N1, that if she's a physical candidate for chemotherapy, you should consider ordering a gene expression assay to understand her underlying prognosis so that you can, with shared decision making, at least describe to her her outcome if she gets chemotherapy versus does not take chemotherapy. But again, they offer adjuvant chemotherapy followed by endocrine therapy, or the option of adjuvant endocrine therapy plus ovarian function suppression without chemotherapy. So in summary, the data from TAILOR-X, the large node negative trial, and RxPONDER, the large node positive trial, have demonstrated that the majority of hormone receptor positive, HER2 negative breast cancer patients with up to 3 positive lymph nodes can safely forego chemotherapy. I just described to you at length the N1 patients from RxPONDER and the differential effect of chemotherapy as to whether you are pre or post-menopausal. RxPONDER was not powered for subgroup differences, and the data interpretation in the premenopausal patients can be challenging, especially that confounding factors can change over time with her own innate ovarian function. And again, it remains unclear if the benefit from the chemotherapy is from the cytotoxic or ovarian suppressive effects of the chemotherapy. What's next? Well, I just want to quickly review some of the things that are being planned or are ongoing in women with lymph node positive breast cancer. So in postmenopausal women, since there is no chemotherapy benefit with a recurrence score 0 to 25, where do they start to see chemo benefit? Does it happen at 26 if they're node negative? Does it happen at 26 if they're node positive? Are there clinical features that could be added here to better understand her underlying prognosis on top of her recurrence score if it's 26 to 100 if she is postmenopausal? The Southwest Oncology Group is planning to do a meta-analysis looking at the recurrence score and the clinical features of tumor size, grade, and probably other clinical features to see if we can better define where they may be able to get chemotherapy benefit. But the problem with RxPONDER is we're not following any of those patients with recurrence score 26 to 100. And so we have to go back to the SWOG 8814 trial for node positive and the B20 for node negative women. For premenopausal women, I've said this now multiple times, is the chemotherapy benefit in younger node negative women with a recurrence score 16 to 25, or node positive women with a recurrence score 0 to 25 from chemotherapy, ovarian function suppression, or both? We will need a phase 3 randomized trial to answer this question. Currently, the NSABP is actively discussing that trial and running that trial. It is engaging other cooperative groups for their willingness to participate in the trial, as well as multiple international cooperative groups. So stay tuned. I believe that trial will happen. The question is, what will the trial be? Will it be all N1 premenopausal patients? You use the recurrence score 0 to 25 and randomly assign her to chemotherapy with or without ovarian function suppression, randomize her to chemotherapy or ovarian function suppression? And how do we think about the CDK4/6 inhibitor in that case where women we know are at higher risk? And the second interesting question is, people are beginning to ask is does the recurrence score change based on where a woman is in her menstrual cycle? She's in the follicular phase or the luteal phase, and she's got endogenous changes in her hormone levels. Will that influence the recurrence score? We now have 2 ongoing studies that are being undertaken that will hope to answer this question. Mitch Dowsett from the UK has looked at this and recently published on it, and he did not find evidence that the recurrence score changed with where you are in the menstrual cycle, but we'd like to nail that down since it is so critical in premenopausal women to understand ordering a recurrence score and what to do with the result, and have confidence that the recurrence score is giving you the true information. And then radiation deceleration, MA39, being led by Dr. Whelan and Rakovich, will help us understand whether the recurrence score result can predict the benefit or lack thereof with regards to extranodal radiation in patients with 1 to 3 positive lymph nodes. So there's a little bit of a whirlwind on Oncotype and where we are right now with node negative and node positive, with dozens of ongoing trials that are being undertaken. But I'm going to end the presentation there. Thank you. If you want to reach out to me ever with any questions, I'm Christy Russell, but crussell@exactsciences.com. And I'll end the slideshow and we can open it up for any questions.
Thank you so much, Dr. Russell. That was excellent overview. I wonder if anybody has any questions. Please feel free to raise your hand or type it in the chat box. I can see Dr. Trudeau has a question. Want to go ahead, Maureen?
Sure. Thanks, Kasia. Thanks, Dr. Russell, for that talk. That was very, very good and a nice way to put all the pieces together.
Thank you.
I do share concerns about whether the improvement in survival or outcomes with the 0 to 25 node positive is all due to endocrine therapy, and a bit nervous, say, about people assuming that's the case and ignoring adjuvant chemotherapy. But that's just a comment. My question is, was the RxPONDER analysis adjusted for the multiple looks at the data in terms of statistical analysis?
Yes, that's my understanding. The analysis is being done by Bill Barlow, who's the Southwest Oncology Group statistician, who I'm presuming you've worked with, Maureen, but a very careful statistician who has been doing multiple analyses that were pre-planned to try to address all of the different clinical features.
Okay, thank you for that.
Mm-hmm.
I don't see any other hands up at the moment. Maybe I'll ask one question.
Sure.
So Dr. Russell, you mentioned that that the patients with micrometastatic disease were represented in both the TAILOR-X and the RxPONDER.
No, they were not. So they were excluded from TAILOR-X. TAILOR-X is purely node negative. If you had micromets, you were not eligible for TAILOR-X. So the only patients that we're aware of are micromets are sitting in the RxPONDER trial. We don't know the total number of women. They did not do the analysis in the postmenopausal women because they weren't getting chemotherapy benefit up to 3 positive lymph nodes. So they did not analyze the micromet patients from who were postmenopausal. They only did the analysis in the premenopausal women because I think all of us were hoping that their risk was low enough that we wouldn't see any chemotherapy benefit. Numbers are small, but it still suggests that there is.
Okay, thank you. Thank you for clarifying that.
Yeah.
And then I guess waiting for people to raise their hands, I might ask another question as well. I'd like to mention Jan sent out some information about our Ontario guidelines for program and evidence-based care regarding multi-gene profiling assays. So I encourage everyone to take a look at that. And I'm curious, in terms of those recommendations, there was some recommendation about, potentially using clinical judgment to guide decision-making. So if somebody's high enough risk with N1 disease, perhaps you might offer that person chemotherapy. Could you speak to that a little bit? What would constitute, in what cases would you recommend, offering chemotherapy without necessarily needing a multi-gene profiling assay?
So I'm not going to make any therapy recommendations because I work for a company that sells the Oncotype. And I haven't practiced in 5 years, so any recommendations I make should be ignored. I think the question is, are there clinical features that can help you predict the recurrence score? And many people have tried to do that. People continue to try to do that in order to avoid ordering an assay that is considered to be expensive. I think that really there's a stronger association of grade than anything else with the recurrence score. But even with patients who are grade 3, the huge majority do not sit 26 to 100. Ki-67, I don't know if that's something that is commonly done in Canada. And it'll probably arise, if it's not, it'll arise again because of the Monarchy trial. And at least the FDA recommendation of a Ki-67 over 20%. Those data feel very controversial to me as well. And we are hoping actually we're working with Lilly for consideration of getting the monarchy specimens to do oncotype on those patients to try to understand, is there something better than that Ki-67 of 20% that can help find a group that is and is not benefiting from a moderately toxic but very expensive 2 years of adjuvant endocrine therapy. I think the meta-analysis will help a lot, Kasia, that is being done looking at the clinical features on top of the recurrence score to understand when you have the recurrence score, what happens to the underlying risk of the patient. But for every analysis that we've done, we can't find a specific single clinical risk feature that would lead you in a direction of saying, I can predict the score is going to be this and thus I can avoid therapy. That's especially true in the postmenopausal women. And in the premenopausal women who are node negative, I think you have that question as well. Who can I figure out is 16 to 25? Clinical risk certainly is prognostic for these patients. I didn't really answer your question. I think we've looked at lots of analyses for people who are trying to guess the recurrence score. So it doesn't need to be ordered. And at this point, we haven't seen an algorithm that has a high enough level of evidence that could supplant it. I think the question's back to you. Is it age? Is it under 45? Is it under 40? When do you get so nervous you don't want to score? You're just going to give chemotherapy. The other question I have is for premenopausal women who are node positive. Will you offer the same chemotherapy if her recurrence score is 2 versus 20? Will you offer everybody the same chemotherapy? If you do, then I'm not sure about the clinical utility. Do you offer every premenopausal node positive patient ovarian function suppression? If you do, then you can question the clinical utility, right? If everybody's going to get the same chemo, if everybody's getting ovarian function suppression, what you lose is just the knowledge of the underlying prognosis of the patient with or without chemotherapy. And that's related to shared decision making, but you've already made your decision and offering that decision. I would suggest that people use the Oncotype to make the chemo decisions differently. And I think that they may use it for ovarian function suppression differently as well, if they're offering chemotherapy and the woman's still having periods. So it's not a recommendation. It's more about making people think about what they would use, what they would use the score for if they had it in these patients.
Great, thank you. Thank you for that. I'll give the group another opportunity to ask questions, a hand up or a question in the chat. Okay, I think you addressed everything very thoroughly. Some of those controversial aspects were very clearly presented in your slides.
Good, thank you.
Dr. Russell, yeah.
And I just want to say from a personal level, I've always really appreciated the partnership that we've had with your group, the organization, clearly with the radiation oncology group there and all the wonderful work we've been doing with Dr. Rakovich. But for the entire group, I just want to say how much I appreciate the high quality of science and data and our partnership, and hopefully more ongoing.
Absolutely, we value your partnership as well. And thank you again for speaking today. Really appreciate it.
You're welcome.
Maybe
Thank you.
You can come to Toronto.
I'd love to anytime. Maybe a little warmer.
Yeah.
Okay.
Okay. Thanks so much.
Bye.